you, you're very much like, you are a physio, you're not, not a human being, but there's that reluctance to share anything about
Mm.
you. And you're very much like, you have to be professional, smart, tidy. There is very much like, you're bare below the elbows, and it was really strict because of infection control. Your hair has to be a suitable length, and clean shaven. It was very quite strict, I suppose. And then coming to New Zealand, when I first started working in New Zealand, and people had watches and all sorts of things on, and mullets, and uh, dodgy looking mustaches, uh, all this different things. And then when you start looking into the cultural safety side of things, that actually, to build those connections with people, you have to let people know a little bit about who you are. Um,
Mm.
and that's how you get your patients on board and learn about it. But that's so different to how I was trained in my early career. So I think it's a
Mm.
really interesting exercise, I feel.
Mm. Thank you. Anyone else? Did the rest of you find that, or what did you draw upon kind of trying to come up with this definition?
This kind of touches upon sort of my big dread going all through my education, because to me, I don't know if I'm just like maybe literally minded, or I get like sort of caught up in the semantics, but to me it almost seems like troubling, because it's almost like you have the professional first,
Mm.
and then it's almost like you're running after to be like, oh, okay, let's chuck all these things on it. Where that's like what it's always felt like, where suddenly you have to like discuss this thing, professionalism, but it's almost done by the time that you're discussing it, like in
Mm.
clinical, and it just, I don't know. And it's always, they always ask you like throughout, they're like, what is professionalism, what is da 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 da, and then I've always just found it like, yeah, like I don't know, not just trouble, like even the word of it is like troubling for me, like in a sense, because of that confusion, that it's almost hard to pin down, and
Mm.
it could be anything. Like, yeah, so yeah, that's yeah, deep struggle to define it.
Thank you. Thank you. Anyone else have any kind of thoughts or feelings as you were trying to nail this definition down?
Oh,
Just
just to follow on from that, I think it's one of those terms where um, people know what you mean implicitly. So you will see someone who's professional and go, that person is professional. But then if someone comes to you and says, how do I be professional? It's quite hard to actually pin down,
Mm.
because like I've certainly worked and met people who, for example, swear, but they're what I would regard as professional. And then there's some people I've met who dress extremely nicely, and I regard them as being unprofessional in some respect. So I don't think it's something where you can say professional absolutely means this, and this, and it's not this,
Mm.
and this. So it's quite, I think, hard to pin down in a literal sense.
Mm. Mm. Thank you. Anyone else want to add to that?
I also think that being professional can be different depending on the population that you're with. Like,
Mm.
I think that's like similar to, I can't remember, wait, what's his name? Thomas, coming from the UK. Like different populations will perceive you as being professional in different ways. So like, I don't know, sharing things about you could be a way of forming a bond and making someone feel more comfortable with you, but that could be perceived as unprofessional. But some people would be like, wow, this has enhanced my care
Mm.
because I feel connected and a part of, like, yeah.
Definitely. Dewi, you were going to say something?
Yeah, I absolutely agree with Tom and Kathleen, because when I wrote down the attributes in the GDocs, I sort of thinks that the question is, how does the patient look at me as a professional GP, instead of how
Mm.
I can be looked as professional. So yeah, what I wrote there is like, look presentable, look tidy. Is it exactly like the patient prefer a tidy GP instead of someone that wearing like jeans or wearing like untidy clothes? So yeah, it's I think it's interesting that seeing how professionalism can be defined in different way with different perspective.
Thomas, you were going to say something?
Yeah, we're just thinking about being, when you are being the professional. My wife's a nurse, and she was taking my kids to daycare the other day, and she drove past, like, heard somebody get hit by a car, and suddenly she was in this professional dilemma of where she goes, well, I'm a nurse, so do I stop? But actually, I've got a 2-year-old and a 4.5-year-old in the back of the car, and it's not appropriate for me to stop. But she just suddenly had this professional dilemma of where is my obligation right now? And she was like, if I was on my way back from dropping the kids off, then I probably would have stopped. But and it's that, all of you guys are doctors, it's that fear. Her biggest fear is always when you're on an airplane or somewhere and they go, is anybody a doctor or a nurse on the flight? And she's just like, that's just the worst thing. It's just that worry. But it's like, as a professional, do you have that obligation to say, well, yes, I am, but if it's on an aeroplane and somebody's, I don't know, having a cardiac arrest, and you're like, yes, but I'm actually a mental health nurse, I'm actually no use to you whatsoever. So it's a really interesting, dilemma.
Yeah, I think it's a really interesting conversation that we're having, and I think what people are drawing on are really some of these core questions that arise in professionalism, like, what are the boundaries of my professional role? And then I think kind of what Dewi picked up on is that question of who defines professionalism. Is it the patient? Is it our colleagues? And also kind of, where does that kind of expectation come from? Do we set an expectation that our GP won't be wearing jeans, and we think our patients want that? Do our patients actually want that? How do we know? Does it differ on the patient group? Is it a thing that we know when we see it, but actually trying to define it is tricky? And then I think that thing that you said, Suad, about running after the definition, I think that's a really, and you're the writer, you've got the really beautiful way of saying something, but it's funny that you said that, because I think that's a bit of what the professions are always doing. There's a lot of research that talks about the kind of elusive definition. Can we have a final definition? Should we have a final definition? And what Thomas picked up on, that idea of like, what professionalism means in the UK versus what it means in New Zealand, and is one better than the other? Probably not. And that contextual idea and the time-bound idea, even that idea of, has professionalism changed post-COVID? And is that what we want? Do we need to push back, or actually is it an opening for us to think about professionalism anew now that we have this different experience to reflect on? So I think all of those things contribute to the challenge of professionalism. And I think, to me, and I recently read a piece that was written for the State of the Science issue of a journal, where these people, they called it opening Pandora's box. Like, do we want to revisit this conversation that we've continually tried to put to bed and say, yep, this is what professionalism is? And their idea was a little bit like, we need to keep thinking about it, and it is going to shift. That's essential to how we think about professionalism, and it ought to be an ongoing debate and a bit of a fluid, ongoing conversation. So I love that we kind of touched on that, even just in trying to nail this down. So if we look at what we wrote in this Google Doc, and I'm looking to the side because I've got two screens here, we came up, and I can kind of see, because there's different styles of writing, maybe where different people were contributing. I see some themes around cultural safety, around communication, around leadership. I saw something about, let's see, there was something about keeping up skills. like continuous professional development, knowledge base. And I think that boundary, knowing what you need to know to do the job you're doing, and someone else wrote, I don't saying knowing to know when to say I don't know. So knowing the boundaries of your knowledge base. And I think that comes up kind of in what you were saying, Thomas, about, is there a doctor in the house? And it's like, well, I'm a psychiatrist, but you know, maybe I know a few things about cardiac arrest, I'm not sure. And like, do you put yourself forward or not? And that's a big question. I don't know what the law is in New Zealand actually about this, but there was a, I forget what the term is in the US. It's kind of like a bystander law that that doctors couldn't be sued if they jumped in to help and something went wrong. Because I think that was often a fear in the US because of the litigious society, that someone might be sued if they tried to help. And yeah, but it's that question of like, what does it mean to be a professional, and do I just jump in any situation or not? And then the idea of appropriate dress wear and language, I think that's a really interesting one. We've added some content, I think it made it into the new module, where there's really a tension around that, and an interesting body of literature that's developing. And this is an interesting thing around professional identity formation, and a critique of the literature that's developed how we teach about professional identity formation. Interestingly, really treated, especially in medical education, students, there's this phrase that some medical students wrote a paper about this, where they said, we're not blank slates. We don't come into medicine as these kind of empty vessels for you to fill with no previous life experience. And in fact, the professions are asking for and actually saying we need more diverse health professionals. That's really important. And what that suggests is that we're coming in with something. You think we're coming in with something, but then the way we teach professional identity formation, the way we talk about professionalism hasn't kind of reshaped in kind. All of our research and the knowledge base on which we build that suggests that we have these quote unquote neutral medical students or neutral health professionals coming into training. And actually what comes with that is really thinking about these things that we've been raising, like what is professional dress wear? A really common kind of train of conversation that comes out of the US is like, what about professional hair? Are dreadlocks professional? And traditionally there were these ideas that that was maybe seen as unclean, but actually that's not true. And that's kind of a cultural designation that actually is oppressive. And so these ideas of like, yeah, even if we say appropriate dress wear, there's that question of like, well, what's appropriate? What does that mean? And so I think it highlights these ideas that we may think of some parameters of professionalism, but then how we then interpret that and police it is another story. So I'm just going to share. I think we've touched on many of the things, but I'll share just a definition that some scholars came up with, and hopefully you can see these slides. Can you see that slide, or has it left your screen?
Yeah, we can see the slide is your presenter's view.
It's the presenter view. Okay, let me just stop share and try that again and get the right screen. Better?
Yeah.
Okay, so so this is a definition that was developed by some scholars in 2009. And what they did was they were on this quest that we are on to say, what is professionalism? So what they did was conducted a literature search and did a thematic analysis of the definition of professionalism used across 50 articles. And they identified 5 clusters. This idea of adherence to ethical practice principles, and that included things like honesty and integrity, confidentiality, moral reasoning. And this table appears in Canvas. So just so you know, you can refer back to it. Thinking about effective interactions with patients and people who are important to those patients. So I saw nicely someone had added the people around patients, like caregivers. And so things like respect for diversity or uniqueness, politeness, empathy, demeanor, shared decision-making with patients, professional boundaries. So these are all things that we kind of came up with. Effective interactions with other people working within the health system. So working with your colleagues in a professional way. And that makes me think of what you said, Lee, about like someone might look professional, but you don't think, you know, they're wearing the professional dress, but they're not professional. And I think my head went to the kind of, I don't know, a professional that yells at their colleagues. And maybe that's what I thought of. I'm curious what you thought of when you were thinking about that, if there was a specific person or type of person that came to mind. Ideas of reliability. So I think someone had come up with punctuality, accountability, taking responsibility, and then commitment to autonomous maintenance and continuous improvement of competence. So that's kind of ongoing professional development, but also, and I think this is really interesting, not just as yourself, but doing those leadership and management roles, and then thinking about systems, advocacy for changing systems, looking at audits, advancing knowledge, thinking about systems in general. So not just about the individual, but the system that we're working in. So what do we think about that? I think we touched on many of these things. How do we feel about this kind of overall definition? How does it fit? And does it fit, because this comes from medical education, but I'm wondering for folks who are in different professions, whether that speaks to your profession.
Yeah, it all fits with what I would see as a physiotherapist. So
yeah. Caitlin, any thoughts? Does that feel familiar to you?
Sorry, just unmuting. Yeah, that's all pretty relevant to sonography and radiography.
Yeah, it's interesting. I think someone had written in the Google Doc something about the code of conduct for your profession, and it's interesting because for a different lesson I was teaching on professionalism, we had tried to find within New Zealand the different professions way that they had defined professionalism. And it was actually quite challenging to find because often it was buried in different places. And so it's often in the code of conduct, but it might not have been specifically called professionalism. Some had a really clear professionalism definition. So that might be an interesting exercise to look up in your college or your regulatory body to see how professionalism has been defined specifically. And I just want to share just two more slides that I think we've really touched on this and maybe really banged this one down pretty clearly. But what's interesting, I think this is a relatively recent paper by Ong et al. And this, interestingly, I was looking at this paper from 2020. It's written actually by a whole bunch of medical students, did this big literature search, and they were trying to understand how medical schools had nurtured professionalism. They looked even wider than the Wilkinson et al. Paper, so 1990 to 2019. And what they really touched upon, and they were medical students from Singapore, is that they added this piece to their definition, which I think is really important, which is that it's an evolving concept defined by sociocultural factors. So it's contextual, it's time specific, and also that it's surrounded by prevailing medical philosophy. And I think that's another really important thing to think about is like, what is the philosophy of that time? Who decides? And I think that comes back to this question of who has decided what professionalism is? How does it change? Whose values does it reflect? And that comes to this next paper that I want to highlight, which is really speaking to that question of power in professionalism. So this was a paper where they spoke to, I think it was medical residents specifically in the US, so post-medical training in that second layer of training in the US, and they spoke to folks who came from minoritized identities, so people with experiences that were underrepresented in medicine, and asked them about their experience of professionalism. And what's really interesting, what they developed through these interviews, was this idea that professionalism wields power. And interestingly, they found both that it could be oppressive and homogenizing in the ways that we have kind of touched on in our discussion, but that it can enforce racism and encode dominant norms. So difference conflated with unprofessionalism. So things like dress, things like sharing bits of yourself, how you use language, dominant norms equated with professionalism in ways that could be oppressive. Folks anticipating being judged, so that idea of stereotype threat, and so in that anticipation, professionalism felt oppressive. Having double standards, how you apply professionalism differently to different people, how institutional policies enforce discrimination. And one of the ways they talked about that is how institutions lacked support for advocacy, or the way that dress codes were written really encoded these racist ideas. And then conversely, these folks talked about how professionalism could be liberating or empowering for them. It gave them agency, it offered ways for them to advocate for their patients, for themselves or colleagues, and gave them a sense of legitimacy. So having this code of what a professional is gave them these common expectations that they could say, okay, if I abide by these expectations, then I know that I'm being professional, and nobody can tell me I'm not a professional. You know, that might be a false sense of security, but it was something to hold on to. It gave them agency to say, actually, this teacher is not being professional when they're doing things. We have a code here, and what you're doing is in contradiction to this code. So they could use it as a tool to hold people accountable. And then it gave them a way to say, how do I respond to this? Well, I'm going to be a professional. You're not being a professional. I know what a professional is, and I'm going to embody that. So it gave them a tool to endure racism or microaggressions, and also gave people a signifier of belonging. I belong to this thing, it has this code of practice, there's a way that I can set myself apart, and it gave people a way to situate themselves within professionalism. And, you know, I'm interested in what you all think about this, because I have a lot of thoughts about it, but I'm curious whether anyone has any reflections on this work.
I was just struck by that, as you were describing it, that it looks very similar to, I think, what occurs in supervision, and which is a part of being a professional, I guess, in that you can, I guess, supervise people in an oppressive or homogenizing way. But you can also do it in a way which is liberating or empowering for the trainee or the person you're supervising, and they can lead to very different outcomes. Was just what my thoughts were as you were talking.
Thank you.
Yeah, I don't think I've ever thought of using professionalism as an oppressive tool, but until you've mentioned it, and then thinking about it, think about in New Zealand where it could be used by our Pākehā population to to use those stereotypes and to use it to make people match what we believe is the right thing as a, you know, dominant population. And so it could lead to inequity amongst our professional groups, which is interesting because we see that our workforce in New Zealand is not representative of the population that we serve. And this could be, you know, we know that there's lots of institutional racism and stuff out there, and this could be one of the ways that it's impacting on that. And I'd never really thought about it until now.
Thank you.
Yeah, I never thought that professional can be like a double-edged sword like that. That when dominant norms equated with professionalism. So I think this is the place where cultural safety step in. So yeah, the GP, I mean, in my context, is the GP. So the GP can like provide care based on the patient that she or he is meeting, not stereotyping all of the patient that is going to.
Yeah, thank you.
I just wanted to comment that I think I've often perhaps over-signified and over-focused on the actual oppressive homogenizing part of professionalism. And I guess because I think I've been quite aware, even way back at the selection of becoming a doctor, how that whole process is, you know, it pre-selects for who it wants, you know, and just as Tom said, it sort of excludes like so many people from the outset. So I've always been aware of that. But then it was, so I'm like in shock at the liberating, empowering part of it. So yeah, that's really cool, and perhaps yeah, that's cool thinking.
Yeah, and it's an interesting thing because even as and I'd encourage you to read the paper if this is something that interests you. It's an interesting paper, and while it's in the US context, I think it's worth then reflecting on your own context and how it might apply, or might it look different. But when I read the paper, I thought I can see where it's liberating and empowering, and it's kind of in the sense of self-safeguarding in an oppressive system. So it's like, it's liberating. It's a way to kind of speak back to power. Like, yes, professionalism is about advocating for patients. So don't tell me to not do that. So it's still within that oppressive context. So it's a little bit of an interesting thing. But I did like how it showed this kind of dual way that it could be used. And actually, I think for to me, what it suggested is that perhaps we could lean into that liberating, empowering thing and think about how we can think about professionalism in more expansive ways. That how could it be more empowering? We say, you know, in tension with that idea of health professions being selective, and yet we want all different kinds of people. You know, we talk about a mirror on society. Well, if we want a mirror on society, then how might professions shift in response? What would that require? Can we just say medicine or physios or medical imaging stays the same while we're asking to, we're saying we need to shift, our patients need something different. So then what does that look like? Okay, so anyone want to add any final thoughts to that conversation?
Great,
Do you
then.
want to jump in?
Sure. Sorry, I forgot to turn on the recording because we had I turned it on now, but I didn't really want to interrupt the flow of the conversation that we were having. But are you guys okay with that?
Yeah, we've got a couple of students, I think, who haven't been able to make it. So
yeah, thank you. All right, so it's now time for a short break, and get up and go for a wee stretch if you want. So we'll take a break until 11. But while you're on the break, I would like you to think about or jot down some notes about what you struggle with professionalism and what you want to achieve for professionalism. So I think we've already, touched on aspect of, how you perceive professionalism. Yeah, just things that you struggle with and things that you want to achieve for professionalism. And we'll come back at 11. To grab a cup of tea or coffee. So for the next exercise, we're going to assign you guys into breakout rooms where you can share what you wrote and talk about finding out the common threads among your experience regarding professionalism. Yeah, I think I'll see how it goes. Maybe I'll give you guys about 10 minutes to talk among yourselves in the breakout room, and then we'll come back. And I'll just randomly assign you into 2 rooms. All right, and if you have any questions, you can hit the help button. I think there's one in the breakout room, and then we'll go have a chat to you. All right. Great, I've restarted a recording. So let's hear from you guys what you talked about in the breakout room. Can you sense any common threads among your experiences? So we'll start from room 1. Who wants to start?
I think one of the most common themes was, do we change ourselves to appear more professional, or do we be true to ourselves? Like that was kind of one of the themes that kind of came in.
Okay, so that's a struggle that you guys
shared?
Yeah. Okay, and what was your conclusion, if you had any?
I don't know. What do you guys think?
Did we have one?
Yeah, I don't know if we did have one. I think that was just a genuine question. Yeah.
Well, tell us a bit about what you talked about then. Do you think you need to change yourself?
We sort of were discussing from various aspects of people's, I guess, personal identity and how that can be in conflict with what you want to present professionally. And I guess trying to find the balance of those 2 things. So not being, I guess, for want of a better word, so professional that don't show any individuality and you're just this professional automaton, but you also don't want to be someone who's sharing everything about their intimate personal lives and appearing too familiar. But that there's some sort of ideal balance, which is very hard to find, where both of those things can coexist.
It's so interesting how you've said that, because it makes me think about so I mentioned this idea of like we want diverse professionals, but then there's a critique where like do we really support students in thinking about how they can bring their whole self, or how, what aspects of yourself do you bring to the profession, so that exactly that tension that you're describing. And in the space that I work in, which is around disabled health professionals, there's been some research that has tried to get at like, how do people bring their disability life experience to their professional role? And what learners really said is like, I want to do it, but actually either I'm explicitly told or either I'm explicitly told don't do that, that's unprofessional, or I'm implicitly told that's unprofessional because we don't share aspects of ourselves. And really, like, I don't know how to do it. So I'm kind of in this muddy gray zone of trying to figure out, and it just comes out at certain moments and not. And so one of the things that literature is, the message that literature is giving is like, we actually need to support students and think about it. And it's interesting to hear you all saying, like, we're professionals, we're teachers, we're not really sure how we do that. And so that could be something to explore, is like, what is a way to embody that in teaching? What would it look like to support learners to share what you've learned, but also maybe share that struggle and work through it together? What could that look like to teach that complexity of the professional, bringing yourself to the profession in a professional way?
I think it's very interesting to hear that you guys talked about the conflict that you might perceive between your personal identity versus your professional identity. Because, you know, a paper that I provided for module 1 talked about the 3 different frameworks to underlie professionalism. It could either be virtue-based, behavior-based, or professionalism. It's about your professional identity formation. But that brings a question about, where does your self stand in that spectrum? You know, from some of the work I did previously, I think it's quite important actually to acknowledge the integration between personal and professional selves. Eventually, perhaps, you know, your professional self will actually become part of who you are as a person. And that integration allows you to resolve any conflict you might have. It's not easy to achieve that level of identity, and people go through exploration of their identity development all the time. There's no end point to it. But if you can somehow find the equilibrium between the personal self and your professional self, perhaps you'll feel a bit better about, you'll get a deeper understanding of what it means to you as a professional. And I think based on today's conversation, we quite often discuss, you know, where does the boundary lies and where does our individuality comes to play when you are developing your own professionalism. So yeah, interesting discussion. So I wonder if you guys talked about things that you want to achieve.
I think we got a little bit sidetracked.
It's all good. It's all good. Group 2, what did you guys talk about?
So we kind of had similar but slightly different themes. But I talked a little bit about the expectations we put on people to be professional, and what are the expectations we have on our students or our new grads to be professional. And it's quite interesting that because some conversations I've had with some colleagues is that that some of the new graduates have been taking a lot more sick leave, and so our impression is that that's been unprofessional because they've been, you know, kind of taking the mick a little bit, you know, abusing the sick leave policy, if you like. And I think some of that's maybe because of COVID, but I think some of that's the expectations we had. I was saying to Dewey that me and my colleague who were talking about it are both UK trained, and I've just during the break looked up the code of ethics and professional practice between the New Zealand Physiotherapy Board and the UK one. And the New Zealand one talks about you need to look after yourself, your own health and well-being as a physiotherapist. The UK does not mention that, the UK board.
Mm.
And so our expectations working in the NHS was, even if you had a bit of a snuffle or you weren't quite your whole self, there was the expectation to come and work and you just cracked on. Whereas with COVID, but also being in New Zealand, I think there's that different expectation, which I think is great. And that was one of the themes that came out in the paper you talked about, Nira, about, balance, availability to others, to care for oneself, which was never something I was taught as a student physiotherapist or as a new grad. And so that struggle between my expectations and my colleagues' expectations and what actually the code of, our physiotherapy code says, and that kind of links in with you guys talking about, do you change yourself and your expectations, or do you have to adapt them? And then Dewey talked about kind of the balance again of that how to balance things. She was talking about the balance between your professional expectation to provide the best evidence-based care versus the patients having autonomy to choose for themselves, and how culture also fits into that, like their cultural beliefs and expectations versus yours, and how you balance all of that in a very complex interaction. And Drew was talking about in a one-off interaction as a GP in an emergency department, which you've not got any of that relationship, and having that bad news, sharing that bad news situation, which was really, really quite interesting. How do you balance that? And we didn't have an answer for that. So our kind of what we wanted to achieve from this was, from myself, was trying, how do we teach what our expectations are, and what is being professional, and how do we teach what those expectations to meet that are. And Dewey's was to hopefully find some kind of balance between professionalism and professional identity and culture and patient decision making.
I love that bit about kind of realizing what the code says. And there's a really interesting kind of maybe hidden curriculum. Also, as you say, cultural expectations of where you've been trained. And it's really interesting that it's not in the UK code of practice. And be interesting. And is that, you looked at the current code of practice in the UK?
I looked at the Chartered Society of Physiotherapists one.
Okay.
Yeah.
Okay.
It's not there.
So it's even now, because I was thinking, was that a historical thing that it wasn't in there? Because that's quite often it's coming in more now.
Yeah.
But it's that interesting well-being piece as well, right? There's an interesting paper some colleagues of mine wrote that was about mixed messages in training about well-being, where sometimes the code of practice will say something like that, or there's a lot of rhetoric about take care of yourself, but then when learners try to enact those ideas, at least in the way they see that happening, there's some pushback, or systems aren't set up to really allow learners to do that. Like, for example, to seek mental health care while they're in training, or something like that, that they can't get leave to do that. So then, do you really care about our well-being or not if we can't do the things that we need to do? I also think about some colleagues in Canada who told me about they were doing a curriculum transformation, and there was, like, I don't know, they call it like white space or something in the curriculum, where there weren't classes scheduled, like there wasn't FaceTime that learners had to engage in. And he told me there was this debate because, it's like, okay, they can use that time to catch up on reading or to do the assignments or whatever. And somebody on the committee said, well, what if they're doing their laundry during that time? And it was like, well, we can't give them time to do their laundry. Like, they have to do that when we think they should be doing their laundry. And this was like a genuine debate they were having. And it's like, well, maybe they need to do that. Maybe they need to do their grocery shopping. Like, why are we trying to control how students manage their time? But it's this interesting thing of like, we have an idea of what it looks like to be a good student or a good, and then reflecting on our code of practice is an interesting thing to say, well, actually, if we're saying they need to do that, maybe this is how they're doing that. So yeah, it's just an interesting tension.
It's also interesting because I've moved out of working clinically, and so I'm managing a team of people who are helping educate clinically but are non-clinical, and saying that you can work from home and stuff a few days a week or whatever, and that's really interesting. You're talking about doing your laundry and stuff, and there's the we used to have a manager who, if you were there at 8:05 or left before 4:30, that you'd get the stink eye when you were walking in or leaving the department. Whereas now, leading this team, and I've had a number of managers since then when I've been working non-clinically, who are like, I'm not going to micromanage you. If you're turning up late and leaving early, that's on you as a professional to make that call. But, if you're doing the work in the time, then I'm not going to micromanage you. But it's really interesting watching my current colleagues make that transition from clinical to non-clinical, and me going, hey, if you're working from home, you can do the laundry, you can, finish, you'll start a bit early. If you're starting a bit early, you finish early. Don't feel like you need to do long hours. You can go for a swim in the harbor at 3:30, and it's just that really interesting, quite interesting concept and balance of what are our expectations.
Yeah, I think, with time, our expectations and our understanding of professionalism is evolving. And it's interesting that you guys mentioned about self-care and well-being. Is it more of the individual's responsibility to look after yourself, or does the organization you work for actually need to provide, opportunities for you to look after yourself? And we all know the overstretched health workforce at the moment. Do you actually get the chance to take some time off when you need to? And do we talk enough about look after yourself at the workplace? And while you guys were in the breakout room, Nira and I had a conversation, and I think the thing that I struggle sometimes with professionalism, it's about how do we teach it and how easy it is to teach professionalism versus teaching technical skills. So, our conversation so far indicates that professionalism is such a broad concept, and it encompasses skills, knowledge, attitude, values, and how do you instill values in someone, and all your students bring their own values and knowledge to the mix. And yeah, I don't know, how can you really change a person by education? I think, to me, it actually takes a lot more from the student's perspective and make them realize that they need to change and why they need to change. That's a lot more effective than just simply, top down telling them, okay, this is what a professional is. You need to consider taking their understanding of professionalism into account. So yeah. Nira, do you have anything else to add?
Yeah, no, I think it's an interesting question, because this is, of course, a whole course on teaching professionalism. So there's an assumption built into that we can do that. And I think in our professions, we think we ought to do that, and that's a role that we have. But I think it's this ongoing tension of like, well, then how? And if it's this thing that is about values, attitudes, behaviors, like where is the most effective intervention, or how do we think about that process? And I think the other thing that came to my mind as we were on our break was in my work, it's and I'm trying to think about like how does this fit into professionalism, but often what I see happening with disabled learners is that really restricted ideas of what a professional is are used, or very rigid ideas are used to exclude people from the profession, or to kind of create barriers. And that rigidity kind of but often that's about technical skills, right? Like every doctor must be able to do chest compressions and resuscitate someone. Whereas, you know, I know a doctor in on the Gold Coast who is tetraplegic, and he couldn't do chest compressions, but he works in an emergency department. So thinking about how those roles are defined is, and I think it fits into professionalism, and that idea of like, what is a professional? How does that work into the way we structure our training? It's the knowledge, behaviors, and attitudes, but it does figure into that larger definition of like, if you know, I'm thinking of another physician who has low vision. He's an internal medicine physician, so I think he practices more like a GP in the US. He has low vision, and he knows what he can and can't do, and he relies on his practice partners to say, can you have a look at this, or can I ask you to read this thing for me that is in really small type? But his practice partners also ask him about things that they know that he excels in. And he's an amazing physician who actually has a practice of many disabled patients who gravitate towards him because of his kind of cultural expertise in disability spaces and how he treats his patients. So this question of like, should he tell the licensing board about the limitations, or does that invite all of this kind of legal or surveillance from that licensing board? If he knows how to regulate his own practice, then does he need to report it? Does he not need to? And that's something often disabled physicians struggle with, is this question of what do I tell people? Or am I trusted to regulate my own practice? So some ethical tensions there.
Right. Any final comments before we move on to the next activity? All right, cool. Okay, so now it's the exciting time of talking about the assignments of the course. So, and I trust all of you have got access to Canvas and you had a chance to look online. Lovely, great. I might just share my screen to make things a little bit easier. Okay, can you all see my screen now? Lovely. All right, so here's the homepage for our course. And over here, we've listed a few key dates on your calendar in terms of when the assessments are due. And for a few years now, we've been organizing drop-in sessions. Normally it happens 2 to 3 weeks before a main assessment is due, so that we can use the opportunity to answer any questions that you guys may have, or for you to feedback to us how you think you are doing. So for this semester, we've organized 2 drop-in sessions. They happen at nighttime at 7 p.m. And hopefully the dates work for people. If we just have a quick look at the dates, does it work for you guys generally on a Tuesday at 7 p.m.?
And I just want to highlight, we usually record. Do we record those sessions?
Yes, we do.
Yeah, so we can make them available. And I'm just thinking about you, Lee, and I'm not sure kind of with the time difference. So you can always email us with questions, or you could email us with a question and ask us to answer it, and then we can record it in the session. So even if you're not able to be there, but it's great, I think, when folks are able to come along to those sessions.
Yeah. Oh, thanks for that. I would, I think, normally be at work at 7 o'clock New Zealand time, so I'll probably have to catch them up on Zoom, but thanks for clarifying.
That's
Great.
no problem. Thank you. Yeah, so it's quite an informal chance for us to catch up during the semester. Okay, so that's good. We're settled for the dropping session time. And in terms of the assignments for this course, it's divided into 3 types. So we've got 2 written assignments. They're more like an essay report type of thing. And also we have 3 discussion threads for you to complete. So the first discussion thread is due quite soon, in a couple of weeks' time. And we have some more information about how our expectations for you to participate in the discussion forum. If I can just bring this one up. Right, so normally we expect you guys to lead the discussion on the discussion forum. And you feel free to post responses to your peers, or even ask questions in your discussion forum to add more diversity into your discussion. And when it comes to the assessment criteria, we are looking at a few areas. So, first of all, please contribute to the discussion thread so that each post will be counted as your contribution. And we want you to share your ideas and experiences from your own clinical context. Give us examples to support your claim, to support your ideas will be great. And also make sure that you use relevant literature to support your claims. So we do expect to see 1 or 2 references at the end of your discussion thread, and cite them appropriately within your discussion thread. We're looking at how well you build on each other's contributions. So this could be, posting a response to your peers, or asking questions for your peers to answer. And we'll be looking at the depth of your understanding of your issues. Again, this could be related to how well you use the literature to support your claims. And, we want to see some creativity and critical thinking coming through the discussion thread. So by critical thinking, we mean that we want to see a discussion around different perspectives on the same topic. So, perhaps some literature suggests this, but others suggest the opposite, and how you, as a critical thinker, reconcile the differences and where do you stand in the discussion. And I've already talked about references to readings and appropriate literature. So please limit your post to 500 words. The discussion thread is not supposed to be an essay, right? And Nira and I will read all your discussions and your responses when we mark your discussion thread. Yeah, so for assignments 1 or discussions 1 and 2, it is individual work, and we expect you to comment on your peers' post. And for discussion 3, where you first need to design a clinical scenario for teaching professionalism. And we've given you a reference, an article to read about how you may, the tips for you to develop clinical scenarios to teach medical ethics. And then with this one, we will give you a week to respond to your peers. So I think even though, with your discussions 1 and 2, we expect you to respond to your peers. That only forms part of your marking for the original post. But with discussion thread 3, we explicitly expect you to respond to your peers. And you have about a week to complete that response. Any questions about the discussion thread so far?
I'm sorry to interrupt, Yen.
Mhm.
I'm just going to have to excuse myself to attend another commitment, but it was nice to meet you all, and thank you, Jan and Nero, for the session this morning.
No problem, Lee. Go
Thank you.
well. We'll see you online
Excuse me.
sometime.
Take care.
Okay, and moving on to assignment 1. So assignment 1 is about exploring trust and integrity in your clinical setting. So, we want you to reflect on the crucial aspect of fostering trusting relationships between the teacher and the learners in your clinical setting. So critically analyze the dynamics of these relationships and what are the challenges and opportunities for you to foster the trusting relationship between teachers and your students. And we've given you a couple of examples to demonstrate how you can tackle this assignment. And in terms of when you are structuring the assignment, we expect you to firstly discuss what is clinical professionalism and how does trust and integrity fit into the definition of professionalism. And then you can move on to discuss how you can maintain a trusting relationship between teachers and learners, and also explain why it is important to have such a trusting relationship established. And please provide examples from your own clinical setting where it demonstrates the importance of a trusting relationship between teachers and students. And lastly, we want you guys to think about what are the strategies for you to promote this trusting relationship between teachers and learners in the clinical setting. And again, we have a word limit of 2,000 words, excluding references for this assignment. We do have some flexibility in terms of the word limit. So if it's plus or minus 1%, that's totally fine. But I guess we're not expecting.
Sorry, do you mean 10%?
Yeah, is it 10 or 20?
It's 10. You said one.
Oh, sorry, 10%. So plus or minus 200 words. That's within the limit. But we're not expecting to see a 3,000 word essay. That's all I'm saying. Yeah. And again, at the drop-in session, you can bring your essay structure for us to discuss and to check whether you're on the right track. Any questions or comments? Cool. Moving on. The last assignment actually brings us our attention to the overarching purpose of the course, which is to teach and assess professionalism. So for this exercise, we want you to first identify attributes of professionalism that you want to teach. And then we want you to draw up a teaching plan. It could be a teaching plan for a 3-hour workshop or for a series of workshops that you want to conduct at your workplace or at a clinical setting that you are familiar with. And this teaching plan needs to explain, firstly, why it's important to teach the attributes that you chose, drawing on relevant literature, of course. And then you need to lay out what are the learning objectives that you have for this lesson and how you are going to teach it and how you are going to assess the attributes that you've chosen. So the Wilkinson paper that Neera showed us at the beginning of today's session, it's actually a systematic review on how people have assessed professionalism in the field. So that table or the paper would give you some ideas about what are the assessment strategies that can be used. Yeah, and in terms of how you want to teach the topic, I guess, we are wanting to see interactions, interactive session plan, and something that you're really responding to your students' needs in this topic that you've chosen. So hopefully, by the time you reach to the planning stage of assignment 2, you would have gone through the entire course module, and you'll have a better understanding or a better idea of what aspect of professionalism really attracts your attention to. And again, we'll have more chance to talk about the structure and the content of your assignment 2 at the drop-in session. Neera, do you have any additional comments?
No, I think that sounds, I think you've covered everything.
Okay.
I don't know if anyone else has any questions or thoughts.
Just a question to develop the teaching plan. Do you have any kind of pro forma or template for that, or is it for us to design ourselves?
We haven't got a template, but I think, Neera, this could be something that we can develop for the course. And yeah, let us get back to you about that. And I think having the template probably would help you to organize your thoughts a bit more succinctly. Yeah, we can do that.
Yeah, I was actually thinking that as we were talking, especially if that's not a task that you've done before in a course. So yeah, I think that's a good idea.
I mean, I've developed some course outlines before through an NZ QA course, but if there's a particular format you guys are looking for, then that would obviously be useful.
Yeah, absolutely.
Yeah, and I guess I don't know if you guys have done other ClinEd courses like 712. Okay, that's all right. Perhaps we could also offer some more scaffolding around things that you need to consider when you develop a teaching plan. For instance, the idea of constructive alignment and how you do a blueprint exercise. So essentially, constructive alignment means that your learning objectives need to be aligned with your teaching activity and also aligned with the assessment. So, you know, they all are focused on the same topic. Yeah, so we'll provide some more additional information for assignment 2.
Can you develop a teaching session that is online, for instance, rather than face-to-face as well? Is that okay?
Absolutely. So the mode of delivery, it's flexible. It all depends on your clinical context and what you think would work best.
Yeah.
So sometimes, you know, people have developed a series of discussion board activities that went on for a couple of weeks or a couple of months, or it could be a one-off teaching session. So we also want to see a plan that's feasible. So if you're only developing a one-off teaching session, it gives you the parameter to consider what you can achieve by the end of the session, versus, you know, something that's a 10-week long commitment. Then, you know, you can stretch out the content a bit more, and you may be able to add a bit more assessment to it. So yeah.
Do we have to rationalize why we chose what we chose?
Yes, so you need to explain why you chose a certain aspect of professionalism that you want to focus on. And you could use examples or your experience from your workplace to signify the importance of that particular aspect to your clinical practice.
And do we have to rationalize the delivery mode as well?
I think that would be a good idea. So
Yeah.
this is what we are looking, this is where you can showcase your critical thinking. You know, you need to demonstrate to us, okay, you've considered different modes of delivery, but you think this particular exercise or this particular approaches to teaching is most effective. So for instance, why, you know, your choice of small group facilitation activities, why do you think it's better to do a think, pair, share versus having an anonymous poll where people can just, you know, type in anonymously to an online forum? So yeah, so I guess, Tom, you hit the both idea is that we do want you to critically consider and justify your choice of action.
And I think too, you know, it's that balancing of like, say, for example, you work in a setting where we have this 2-hour block where I know that the, you know, students can attend. We have this established professional development mode, and so it will fit nicely into that. And then I think also thinking about what Jan's saying, which is like, is that then suited for the best kind of teaching that you'd like to do? And so kind of thinking about that tension between feasibility and the kind of effectiveness and how that kind of shaped how you developed that would be quite a high quality assignment. I think would live in that tension and talk about it.
Right. And at the end of on the assignment tab, we've also provided some more information about how you submit assignments, you know, our expectations in the marking rubric for participating in this discussion forum, and how you view assignment grades and comments on SpeedGrader. So I think for those of you who've done our ClinEd courses, you might be quite familiar with how you view the feedback. But for others who are new to the program, this could be a very useful link for you to check out. So Neil and I often would make comments throughout your assignment, and then we'll have overarching general comments in the comments box as well. So we do, you know, we do read your assignments in detail, and sometimes we may post questions for you to consider. And if you want to respond to our comments, you can on the assignment tab, where you submit your assignment and you saw our comments, and you can actually write some response back to us, and or email us. Either way is fine.
You don't have to, but you can.
Absolutely.
Up to you. We welcome your responses.
All right. So I'll stop sharing now. Okay. Nira, do you want to?
Yeah. So I think that's the content that we had for today's session. I've been really energized by our conversation. I hope you have as well. I think this is a really interesting area of exploration, and we've drawn out some of the complexities of this. How do we nail down a definition? Should we? How do we enforce it? How do we teach it? And I think that is the journey of exploration we'll be on this semester with this topic. And I'm really looking forward to how you engage with that through the assignments and with each other on the discussion board. And yeah, just welcome any questions that you have. You can feel free to contact Yan or myself. And yeah, just really excited about that journey that will be on this semester. Any final kind of comments or thoughts that anyone wants to share?
I have some.
Yeah.
I was just looking at my notes. The use of AI for assignments.
Yes.
So for our course, it's prohibited to use generative AI to write your assignments. So, it's a course about professionalism, academic integrity as a critical part of your professionalism. And you can use Grammarly to check the flow or grammar of your essay, but we don't want you to use OpenAI or other tools to actually spit out the whole assignment for you. And and I think I haven't had this experience, but my some colleagues of mine, they actually had students using AI to generate the assignment and actually cited AI in the assignment to say, okay, I used AI to do this bit of the assignment, which is, I think the university policy actually says, or even for journal publishers, says that you can use AI, but you need to acknowledge the use of AI. However, for our course, we do not want you to use generative AI. And for the example that I just gave, what AI generated was not accurate anyway. So, we know how you write, and it's quite obvious when AI is involved. I think some of the logic is missing from the examples that I've seen. Yeah, so that's one thing. Oh, and the other thing that I wanted to check with you guys is the mode of delivery for our workshop. I know, we made the decision to have it online this year, but would you have preferred it to be in person? It's just something that we could take on board for next year.
Being based in Wellington, it's been much easier. I not had to try and fly up and fly back down, which is good. I did ClinEd 715 last semester, and again, their first day workshop was all online, and I think it works fine. Most people are pretty good at participating, and you get that discussion, so I think it works quite well. And it's also really useful to have. I found in 715 having the Zooms recorded to go back and talk. Think about what you talked about and what the discussion was. It really helped me with my assignment. So that aspect as well, being able to go back and not just rely on whatever notes I've scribbled is really useful.
Yeah, that's good to hear. I think yeah, we do think, well, face-to-face interactions are great, but I think it might pose additional barriers for people to come participate. Caitlin.
Oh, I was just gonna say, like, if everyone was in Auckland, it would make sense. So if you ever got like a cohort that was in Auckland, I prefer like face-to-face interactions. Everyone's different, I suppose, as well, and has different limitations and transport and things like that. But I understand that like not everyone's in Auckland, so like yeah, it makes sense that we did it online. But if you ever had a cohort that was all in Auckland, you could probably pose the question. I don't know.
Yeah, it's a good point. I guess we could have had a face-to-face version where people can join us online as well, but I think that dynamic actually makes it harder to facilitate the group activities and just I think for equity reasons, we stick to one mode rather than having a mixed mode of delivery. But yeah.
One of the things that's drawn me to the ClinEd courses generally is that a lot of it is online, so it's made it easier. And Lee coming in from Darwin again, I think it I'm looking at moving to Australia later on this year, and it means I can still do a course next semester because the majority of it is online. So it does mean I can continue that journey whilst not having to come to Auckland. So it is helpful. But yeah.
Perhaps we need to make Auckland a bit more appealing for people to come and live there. We already have too many people in Auckland. Anyway, great. So if there are no further questions, I think we're done for the day. And let's
just
go out.
Referencing wise, sorry.
Oh, sorry. Good point.
Do you is it APA 6th or 7th? You guys don't mind?
I honestly don't mind APA. If you can do 7th, that's great because that's the most recent style. But if you can use APA 6 well and consistently, that's fine too. Or you can use Vancouver. We just want to see a consistent referencing style. Yeah. Being applied throughout your assignment. Yeah. Don't mix and match.
Yeah. Because RefWorks, obviously we can get through Auckland Uni, which is quite useful for anybody that's not used it. I find it really useful for my last assignments. So
the only caution that I give you with using those systems is to not trust that the system has pulled all the correct information out of the reference. So that was something I learned the hard way when I started my PhD. I thought, oh, this is great. It's just doing it for me. And my supervisor was like, you need to check it. And I see students do that all the time. So just, it's RefWorks or Zotero or any of those reference management systems are great. Just make sure that you're double checking how it pulls the data off the papers. Swat, you had something?
Sorry, this is slightly backtracking, but I just wanted to clarify something with the discussions because it says there's a due date, but it sounds like that's actually, we probably should be actually having discussions before that due date so that we can actually, so just to clarify, that's the case.
Yes, absolutely. So, if you can, post to the board a week prior so that you get the chance to respond to your peers. I know it's not always possible. That's why for one of the threads, we actually gave you guys more time to respond to your peers. But
that's a really good question. That's the kind of cutoff date that then we go in and start marking after that. So it's that you want to have an opportunity to have some interaction before that deadline.
And at least 2 of the discussion threads are embedded within the module. So as you go through the module, you can just start populating your discussion for your peers to view.
Yeah. Great.
Lovely. All right. Great seeing you all today, and I hope you enjoy the course. Feel free to reach out to us whenever you feel like it. Okay.
Take care.
Bye.
Have a nice
Thanks
day.
very much.
See ya.